Good morning, everyone. I'd like to start with a brief aerobic exercise. Let's model the way, right? I want to start with a rousing applause. Take two hands, clap together furiously. We're going to do this for 10 seconds. Go. All right. That felt really great, so thank you for that. But I want to imagine that this is oncology, and this is the group of individuals that you care for, people living with cancer. Okay, so I want you to take your oncology hand, and I want you to try to clap without touching anything or anyone or any piece of furniture. Clap. See how much noise you can make. How successful are you at clapping? It's not very successful. This is the concept behind the business case for people working with oncology together to be able to have an action-oriented outcome, a value proposition, the new business case for cancer. We cannot be effective if we do not engage individuals. I hope that I'm going to be able to convey that. I am going to be a little bit of a storyteller this morning, but I then will follow up with data, real data. So let's start talking about the new demographic. Last night, for those of you who heard the presentation by Ellen, saw really great information on genetic counseling, but the first thing that she said was that the number one risk factor for cancer is aging. Well, this is the demographic. We have 10,000 turning 65 every day. We have a doubling of older adults occurring in this country. And they're not just doubling, they are skewing older. So right now we have the younger, sexy senior on the tennis court with somewhat controlled high blood pressure and a host of other chronic conditions. But the age, the fastest growing age is the 85 plus. So we are not just going to be having a doubling of older adults. We are going to be having older adults that skew older, and you are going to see not just cancer, and 63% of those people who live with cancer are older adults. That is the bolus of the people that we are serving. But you are going to see people who have multiple chronicity, multiple uncontrolled chronicity, dementia, all of these things superimposed. So I would just say aging is the new black. Now, in all of this, I'm going to drive home two messages to you. I think it's important to say what the messages are up front, because if you don't take them home, what good have I done? And those are treatment that doesn't meet the goals. This is the number one driver of avoidable costs in cancer care. Treatment that doesn't meet the goals. And the second, and this one may sound a little bit strange to some of you, but is the absence of community-based support. And when I say that, we are a system perfectly designed to have somebody show up at the emergency room where we don't want them to show up. And I will be talking about strategies to reduce both of these things to improve the value proposition. Now, I want to make sure that we're all on the same page about what a value proposition is. Some of you may be aware of the words that Don Berwick, when he was at CMS and previously when he was at the Institute for Healthcare Improvement, used. He calls it the triple aim: better health, better care, lower cost, right? How many of you are familiar with that? Triple aim. Okay. The other way to look at value, which is another term that people throw around, that is the same or better care at the same or lower cost. So that is quality over cost. You want to improve quality as you decrease cost. That is the improvement of a value proposition. These two things are the biggest drivers of avoidable spending in cancer care, and they are the biggest opportunity to be both person-centered and the biggest opportunity for you to drive that value proposition, to reduce costs and improve care simultaneously. And I will give you some dollar figures around this. So I'm going to tell you a little bit about myself. Professionally, I'm a senior program officer at a large healthcare foundation. I'm the program officer who is responsible for most of the nation's investment around reducing avoidable readmissions. I work with all of the major folks in the field. I work with CMS, with AHRQ, with NIH. I am a person who has been deeply involved in systems redesign. I am a nurse, but I have always focused on a systems perspective around cost and quality. That's my entire life. I'm somebody that you probably wouldn't know, but you would probably know about every bit of work that I've ever done. 3 years ago, though, my life changed, and I found a red spot on my right breast. I went to my own primary care physician, who looked at me, and I thought that I knew what it was, and her look basically told me that she knew what it was as well. She sent me for some scans, and it was confirmed after doing a biopsy that I had something called inflammatory breast cancer. Now, I'd like to get an idea in this room, how many of you have a clinical background? Put up your hand. Any kind of clinical background. We like all clinical backgrounds. And how many of you have an operations or payer, other kind of background? Excellent. Okay. This story is a universal story, but this is going to drive home where your opportunities lie, and we'll get a little bit more granular later, but this story may be helpful to illustrate to you what it's like to experience cancer and why we can be able to do much better. Inflammatory breast cancer is a rare form of cancer. So breast cancer is one of the most common cancers. Inflammatory breast cancer is one of the rarest. About 1% of breast cancers are inflammatory breast cancer. And breast cancer today, about 90% survive to 5 years. And many, many people survive much, much longer. Inflammatory breast cancer, 40% survive to 5 years. And the only reason that that overall number is around 87, 90% for overall, it gets pulled down by those inflammatory breast cancer people. Inflammatory breast cancer is the diagnosis in breast cancer that you wouldn't want to get. And it looks different. And it's not a tumor, a lump that you can pick up early. It floats freely. And when it clumps up, it appears on the skin. It looks like the skin of an orange. They call it peau d'orange. It is a very special look, and people think they have an infection on the skin, but it's not. I knew what it was when I saw it. I knew what I had. And when I went to get it checked out, the night before going to have the biopsy done, I did what many of you in the room would do, a complete lit review. I looked at everything that was going on around the country. I looked at who was doing it, how well they were funded, where better treatment modalities existed. I looked on the National Cancer Institute's website to look at what are the normal kinds of approaches that are generally well received. What gets the best outcome? Where's the value proposition for me? I didn't yet know that I had it. But it had such a unique look to it that I really thought that's what it was. So I tried to arm myself with information. And to be honest, you're all bright people. If something happened to you or within your family, you would want to be armed with the most information you could have before going in and seeing your healthcare provider. It's not rocket science. You can read it. Medline Plus, it's in humanese. It doesn't have to be in medicalese. You can get basic information about what are the approaches to use and what's the likelihood that I'm going to live a reasonable amount of time. You know, what's that prognosis? What's that likely course of the disease? Well, over the course of the night, I read that 40% live to 5 years. Very sobering. I read that there have not been many advances made in this particular disease, that because it is a rare form of cancer, there isn't a lot of work going on, and that there was one person who was the most funded, who tended to work in producing a lot of the guidelines about care, and I knew in the back of my head that I would, if I was diagnosed with this, that I would see my doctor, and then I would go and travel to this other person and find out if there was anything that wasn't yet in the literature, if there was anything going on, because we know there's a gap between when things are going on in terms of clinical trial and when they're actually in practice. The gap is about 7 years, at best. That's to get it into practice. That's not for it to go wholesale. So we knew that there might be things going on. Well, when I went, they took, after the biopsy, they took a scan of my body, and they found a hot spot, an area on my lower spine. Now, for those of you who are not clinicians, they inject you with a radioactive sugar, and it moves around the body, and it shows an area where there's a lot of activity going on, where there's repair or metabolism, where the sugar is being eaten. It shows up as a hot spot on a scan. And I'm sorry for those of you who are clinical people who probably are going to want to move faster through this, but I just want to make sure everybody's on the same page. So here I had a hot spot on my lower spine. Well, it could have been that I wrenched my back. Very common, right? Everybody can wrench their back. I happen to be a surfer, and not this kind of surfer, this kind of surfer. So I actually do wrench my back quite a bit because I happen to like surfing. I'm very bad. I'm a really mediocre surfer, but I enjoy it. So it was entirely possible. The only way to know whether that spot on my lower spine was actually cancer would be to take a biopsy of the bone, to go in and to remove a piece of bone in the lower spine. That's gotta hurt, right? I thought, oh, that's not a good thing to go through. But I needed to know that. Why did I need to know that? Well, I needed to know how far advanced the illness was to be able to understand what was the best possible approach. I had to get a good picture of where I was. If I didn't know where I was, I could be throwing everything at the disease, and the disease could have already been so far progressed, and that might not be the best way to go. So I decided I was going to have the bone biopsy done. And I decided I needed help. I asked my mother to come up, my mother, who is 70 years old and speed walks 5 miles a day. My mother came up. If anything, it was going to be great company. We were going to have fun. And in the meantime, I made an appointment to see that individual who was in another state, who was highly funded in my rare form of cancer. Well, I had the bone biopsy done, and I can tell you firsthand that a bone biopsy is not a terribly uncomfortable thing to have done. It felt like getting a noogie in my lower back. Do you remember noogies? So it really wasn't a big deal at all. Sounds very bad, but it really wasn't. So here I had my mother up visiting, and I was feeling great, and we went off to this other state, and we were walking around the city the night before we had the visit, and I got a phone call from my oncologist in New York. And my oncologist in New York said, "I'm sorry, I have bad news." Now, before I had left on this visit, she told me that if we caught the cancer early, we would probably recommend going for more aggressive care because I'd have a longer, better life. But if the cancer were further spread, I should consider holding on to the quality of my life for as long as possible. And she said this because she asked me what I wanted. And I told her I wanted the Niagara Falls trajectory. The Niagara Falls trajectory looks like this. I start out with good quality of life, right? You see me now, right? I feel good, I'm able to go, do, work, play, right? Good quality of life. And I end here. I'm doing a graph right in front of you. Do you know what here is? This is the universal here. This is where we end. Well, I wanted to go good, 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 and drop off the cliff. I wanted to compress that bad time. I wanted to maximize that good time. My doctor suggested 2 different approaches based on where I was in support of that, the quality of my life. I wanted the Niagara Falls trajectory. Does everybody understand the Niagara Falls trajectory? Okay. Well, that evening before my appointment, when she called me on the phone with my mother, it was pouring rain, and she said that it was, in fact, in my lower spine. So at diagnosis, I was stage 4. Do you remember when I said 40% prognosis, survival to 5 years? Well, now it was 11%. That was my prognosis, 11% to 5 years. Now, she didn't tell me that. I actually looked at that, but she did definitely give me a sense of what the long-term survival was for this disease. Well, it was raining out, and hearing those words, my mother and I dropped our umbrellas, and we hugged on the street, and we cried. We cried the whole way home, and it felt like the entire world was crying with us. It was absolutely devastating. But we stopped crying pretty quickly, and I'll tell you why. It is really important to know that for whatever time I have left, I didn't want to be spending it in tears or not doing. I have a limited amount of time. I choose very carefully what I do. If I come here, it's because I think that you are all very important to the care of so many individuals. The work that you are going to do in thinking through payment, in thinking through care, in thinking through quality, in thinking through measurement, in thinking through transparency, in thinking through patient-centeredness. The work that you do is so important for individuals all over this country, including me. And I hope that I'm going to be able to tell you a little bit about how difficult it is for people to get high value in cancer care, so that perhaps you'll do better. So the next day, I went into a medical system that was perhaps one of the most beautiful buildings I had ever been in. Original art, beautiful. There was a person, a navigator who was assigned to me, who walked me over to my doctor. This was just an incredible place. Clearly, it was inspiring to walk in the place. When I saw the doctor, he took the box of slides that I'd brought him that had my biological material in it. He gave me a perfunctory exam, and he said, "This is what we're going to do. This is what we're going to do." These are pretty chilling words. How patient-centered is that? And he had a plan. This is what the plan was. We are going to do the most aggressive chemotherapy we can do. We are going to follow it with a mastectomy, and then we are going to do radiation. And then we're going to follow it with the most aggressive chemotherapy we can do. He said we are going to fight, fight, fight. Of course, my body is the battleground, but he was going to fight, fight, fight. And I asked him just a few questions. I said, okay, well, the cancer has spread from here to here. You can't remove everything from here to here. And let's be honest, every drop of my blood perfuses through my bones, so it really has spread. It just happens to like my spine. So the cancer is spread. It's out of the box. I said, why are you doing the mastectomy? And he said, and this is a quote, "You don't want to look at the cancer, do you?" Interesting. He would suggest doing these things that would have possibly compromised my ability to write and work. It would have caused swelling to my hand, pain, certainly a high-cost hospitalization, probably multiple hospitalizations. I would not be working. I certainly wouldn't be able to enjoy my family in the same way. I'd be much more severely immunocompromised, meaning I could pick up a whole host of other infections, and my life would be forever changed. Now, remember what I said, I have good quality of life, and I end here. I want to go good, 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 and then drop off the cliff, Niagara Falls. This oncologist, one of the best in the country, and providing an approach that was evidence-based, as the other oncologist was providing an approach, evidence-based, both of them on the NCI website, he wanted to drop me off the cliff and have me go out to the same endpoint. Drop off the cliff and go out to the same endpoint. So for me, that was not a good value proposition. But let me also add that over the course of 3 years, I probably have saved my payer about $500,000. I have very good health. I have not gone into an emergency room or a hospital. I feel good. I jet skied to the Statue of Liberty this past summer. I've climbed the Great Wall twice. I work, I play, I have a very good life, and I am getting treatment. $500,000 saved. One person, 3 years. Good health, good care, lower cost. Triple aim, value proposition. I'm going to talk to you a little bit about how that is, because I'm going to tell every one of you here that it is possible for you to make significant inroads, that this is not rocket science, and I hope you take it seriously, because there are huge opportunities around this particular population. So by the way, this is my very first infusion. I like taking lots of pictures. But I really want to prove to you that I am seeking care. Now, I don't have the heaviest kind of chemotherapy. I actually do whatever it is that is the least amount of side effects that also holds the cancer at bay. So in my case, I take an oral medication at night. I take 1 pill every night. It does not make me feel particularly bad. And I take an infusion to keep my bones strong. And take that once a month. And it also is a relatively low-cost kind of a care modality. And I have to say, this is not science. This is not a scientific experiment. But I am doing very well at 3 years. And I have a host of people that I know around the country, unfortunately, who went the other route and are not doing well. And I have to say the treatments themselves have caused them greater debility, and they likely will not live as long as I do. And there is, certainly you can look at a New England Journal of Medicine study around palliative care. People actually do live longer when you do focus on pain and symptoms and quality of life. There are a number of studies around this. I'm not unique. So I want to talk to you a little bit about person-centered goals. We don't often address what goals of care are. And the only analogy that I can say to you, it's like saying, getting in the cab and saying, take me to the airport. Except you end up at LaGuardia when you wanted to be at JFK. We go to doctors, we go to our oncology team, and we just give ourselves over. And we don't really talk about what we're trying to achieve. But I honestly say that if there is a stronger partnership, we have a better chance of ending up in the right place, the place that we want. We can be more supportive of the care because we're trying to achieve the same goals. So I ask, how can care be patient-centered when we don't discuss serious illness with patients? I would guess that anyone who is a clinician in this room would say, I am patient-centered. I care about my patient. And I agree. I think everybody cares about their patients. I don't think that people are trying to do bad things. Even that physician who would have suggested that I throw everything at it. He was doing it for me. He believes that's the right thing. The problem is, again, he's going to take me to LaGuardia and I want JFK. He doesn't know what my goals are. He doesn't know about my Niagara Falls trajectory. He's not on the same page. And so he's going to do a lot of things that are burdensome cost, that are burdensome on me, that aren't going to help anyone or anything because he feels they are the right thing to do. It's what he does every day. And he used those words. This is what I do every day. And I'm sure he does. So let's talk about what patient-centered care is, just to make sure we're all on the same page. Care that is truly patient-centered considers the patient's cultural traditions, their personal preferences, values, their family situation, their lifestyle. The patient is a part of the team. Clap hands with one hand, you are not going to effectively clap. There is a cost and quality outcome difference when that person becomes part of that team. Why? Because studies show that people actually choose less aggressive care when they understand the totality of their situation. And if we go back to that first image that I showed you, those surfers, let me just say I admire those surfers. They are actual surfing champions in their 70s, 80s, and 90s, real people. And the reality is, for older adults, and these are the bulk of people that oncology is dealing with, they don't just have cancer. They have cancer and congestive heart failure and diabetes and high blood pressure and arthritis and a whole host of other things. So you have to look at the confluence of issues in order to even tell them what that picture is. And oncology is not very well positioned to do that. Oncology chooses to look in a narrow way at the cancer, and we have to begin addressing the person. And so everything that I'm going to point you to is about person-centered care, which is a little different than how we currently do things. This is the data, unfortunately. Physicians lie. Physicians shield the truth. This is not my data. This was in Health Affairs. Unfortunately, there's a whole host of reasons. Maybe people feel that they're going to take away hope. Maybe they feel that they're going to get a worse outcome for their patient if they're real with their patients. Wrong. The research does not show that. The research shows the complete opposite. In fact, for seriously ill individuals, when you share information and get very real with them about where their care is, they trust you more, and they have greater hope that they're going to get better care. They are more activated and engaged and more likely to follow the kinds of care that they should be following. This is what we want. This is not what we want. I should tell you that the American Medical Association in 2006 passed a code of ethics. And that code of ethics says that physicians must, not should, must be open and honest and transparent with their patients about their clinical condition. This is in 2006. This is the standard of care in order for patients to be able to actively participate in decision-making. This is the AMA, and this is not a should, this is not a could, this is a must. But the reality is quite different. How do you, as operations people, people who are looking at the systems that you support, how are you going to ensure operationally that people are going to be able to understand where they are and what they should be doing and have a context? This is a major question that you're going to have to ask yourselves. Instead of looking at the narrow, this is the big question, and this is the big nut. This is the nut. This is an answer, something called palliative care. Now, I want to define to you what I know palliative care to be. Palliative care is an extra layer of support, an extra layer of support that can go along with curative treatment, that can go along with chronic treatment, and that can also carry people through end of life. It is an extra layer of support There are people who are going to go through curative treatment and will wave goodbye to cancer. But palliative care helps cover their pain, their symptoms, helps support the family, helps them understand the general picture of their health, helps them in decision-making, helps understand goal setting. Palliative care does this. Palliative care does this in spades. There are palliative care teams in most hospitals in this country, 90% of large hospitals. Palliative care offers this opportunity to be able to go in addition to oncology, to really focus on doing that goal setting and making sure that there's patient-centered care and care that is going to address all those needs that help people typically go in and out of the hospital. You don't want that happening. And best yet, palliative care is not just for cancer. Palliative care is for congestive heart failure, for dementia, for a whole host of complex disease that have symptoms and pain, so they understand the confluence of disease. So there is oncology, and there is an extra layer of support afforded by palliative care. That's what palliative care is. Now, how many of you think palliative care is end of life? Okay. And palliative care is at end of life. It is care that helps support a person at end of life, but it is also curative. It is chronic, which is the bolus of people. Most people are chronic. I, by the way, have chronic disease. Now, I live with stage 4 inflammatory breast cancer. You've all heard my prognosis, but I am not dying unless I tell a really bad joke today. I'm chronic. And most people that you care for are going to be chronic. There are going to be people at end of life as well. Palliative care is for all 3 of those kinds of individuals. Palliative care also covers advanced care planning. And this is, not just the goal setting, not just understanding the big picture, but advanced care planning. So this is a lot of stuff that oncology typically does not want to do. But I should just say that with good advanced care planning, you are able to significantly change the way that people receive care at the end of life. Because people typically want less than what was given. And let me just say, the research shows that physicians want less than what they give their patients. Physicians want less than what they give their patients. Liability-driven care, we have a lot of that. But I should just say that if you have a partnership with your patient, if your patient is expressing what they want, you reduce liability-driven care. You typically will reduce cost. You will improve value. You will be providing care that supports their goals. And surprise, it will be supporting overall what you're trying to achieve as well. All of the research suggests this. There's a great reporter at Forbes, Carolyn McClanahan, and she said 75% of people are unable to make some or all decisions at the end of care. Let me tell you what happens with most of your patients. When they show up at the hospital, one of the conditions of participation is that they have to ask them, do you have an advanced care document? Would you like to complete one? And most people will say, I don't, and no. And it's required to ask. So they just said no, and you can score 100% as a hospital doing advanced care planning by asking them the question and having them say no. It is meaningless use. The advanced care planning that is done typically in hospitals is meaningless use. The conditions of participation for institutions, the kind of metric that is used, will allow you to have no advanced care planning and still get a 100% score. Do you understand what I'm saying to you? Meaningless use. You need to have somebody have a conversation. Palliative care providers are trained in doing this. This is integrated into the care strategy. So goals of care, advanced care planning, and dealing with those pain and symptoms, issues with family, all of the things that have people cycling in and out of the hospital. They don't show up because of the pathology. They show up because of the pain and symptoms. So here's the numbers. If you look on the right-hand side, These are the things that are very high cost. And sorry, I'm going to shuffle pages here. But if you look at the right-hand side, and you see hospital days dropping, for example, from 9.4 days to 2.4 days, that's a mighty big drop. That's actually a 75% drop. Skilled nursing facilities, 6.4 days to 0.9. That's an 80% drop. And ER visits, it's a 61% drop. What increases is the far less expensive, far less expensive home care visits, things that are done on an outpatient visit to address needs to avoid the higher cost care. This is palliative care. This is the numbers. I challenge any one of you to try to get a 75% reduction in hospitalization without it. All the things that you have in your toolbox, you don't have this. Now, this is patient-centered care. This is patient-centered care to the core. Susan Denzer, who was the former editor-in-chief of Health Affairs, called person-centered care the wonder drug of the century. This is it. This is the thing, this is the game changer that we have the opportunity to infuse. You can continue to do one-handed clapping and get all the effectiveness and all the sound that you're going to derive from that, or you can start doing two-handed clapping. Have any of you heard of Choosing Wisely, the Choosing Wisely campaign? Great. All right. This is evidence-based recommendations from major healthcare provision organizations telling you what the evidence actually shows and where you may be able to curtail things that are not evidence-based, not helpful, high cost, low quality, low value. And so I just thought I would show you what the American Society for Clinical Oncology lists under their Choosing Wisely campaign. There are 5 things. These are 5 easy things. I do not want to in any way divert you from taking home the message about person-centered care and palliative care as a conduit for that. But let's go over ASCO's recommendation, because these are 5 things that if you aren't already including, you must, because there is no value in doing these things. So the first, well, no surprise, for people who have advanced cancer, you should be focusing on symptom relief and palliative care. Wow, that's the headline. How many of you are actually doing that? Well, think about how to go about doing that. And again, think about my life and how well I'm living. If you want to make the case for why this is important, $500,000 so far, and I'm being entirely conservative on my estimates, and a great life. The second, reduction in certain kinds of scans for early breast cancer that's at low risk of spreading. Similarly, for prostate cancer. Early, low risk of spreading, these things are not of value. This is according to the American Society of Clinical Oncology. These are not of value. Focus on other patients to do these things, people who are at risk. Individuals who have had curative breast cancer treatment, if they're not having symptoms, this is not the kind of testing that you need to be doing. Not the scans, not this routine blood work for the biomarkers. You are going to be looking at symptoms and doing mammograms. That is the value proposition. You will not do better by doing this. You will spend more doing this, but you will not get a better outcome. So this is Choosing Wisely from the American Society of Clinical Oncology. And the last, it's administering white cell stimulating factors. If they're not at high risk for febrile neutropenia, if they're not at risk, if the risk is less than 20%, you do not do this. You can do this when the risk is greater than 20%. And there is literature for you to know which patients you should be directing this to. This is not what you do for all of your patients. And there are risks to those patients. Pain and symptoms and cost that you will bear, cost that they will bear. This is the group that you do not direct it to. That's not to say that you don't use this, and that's not to say that you don't consider the individual in all of this. You can read more on the American Society of Clinical Oncology's website, but you need to operationalize these 5 points. If you haven't done that, you've just left money on the table, and you've hurt a lot of people. The Institute of Medicine also came out with a report recently called Delivering High-Quality Cancer Care, charting a new course for system in crisis. The headline, Cancer is about older adults who have more than just cancer, and they made a whole host of recommendations for where you can derive value in cancer care. I recommend that you all read it if you haven't already. The number one goal was to engage your patient. And you can read the reasoning behind it, you can read the evidence base, you can read the literature behind it, but it was all because you get a better value proposition. Reduced costs, increased health outcomes, greater engagement, people getting what they want, and surprise, it saves money as well. Engaged patients. Palliative care is part of all of this. Do you see the words palliative care showing up on this? The recommendation in the IOM report is that at the beginning of serious illness, the palliative care is initiated. At the beginning of serious illness, palliative care is initiated. Remember, we talked about that extra layer of support? There will be longer-term, lower costs for that one additional component added over time. You will change the trajectory. And that is if there is goal setting and we are trying to achieve the same thing together. So again, we're going to go back to the take-home message. These are the 2 drivers of avoidable costs in cancer care. And they are treatment that doesn't meet goals and the absence of community-based support. Palliative care, people don't have to show up at the emergency room. They have a phone number they can dial. Somebody is there at the other end of the line and typically will be managing the needs in that crisis so that they're not showing up at the emergency room. Palliative care does all of this. Advanced care planning, goal setting, keeping people out of the hospital. This is what you need. And remember, the picture of that individual is not just a person with cancer. They have a whole host of things. Now, I'm younger. I don't have other things. That's it. It's enough. I don't need any extra things. But most of the people who have cancer typically have 3 or more chronic diseases. And so palliative care manages that confluence. So the new business case. I kid with Don Berwick. I call myself the walking triple aim because I'm better health, better care, lower cost. I have saved $500,000 at minimum, really at minimum. I get to feel good. I really did climb the Great Wall twice since diagnosis. I live a great life. I get to do what I want to do, and I'm still working hard. And I would not have had that great life. This is something that you can offer your patients. You can be proud every day that you offer your patients the very best. You are in a unique opportunity for those of you who are in the managed care environment, in ACOs, working under new payment methodologies. You have the ability to offer it all to your patients. They will appreciate it. And I have to say, you are in a capitated environment, you will benefit from this. It will reduce liability. This is everything that you want. It's everything that people like me want. So I welcome your questions, and I thank you so much.
In Wisconsin, we have 2 major systems, Gunderson, which is, of course, where Honoring Choices started,
Sure.
and also Dean. And both of those systems have now embedded a palliative care nurse practitioner in their oncology departments. And so those folks, the palliative care people, are just part of the team for them. So at Gunderson, if you come in with a diagnosis of lung cancer, any stage, you automatically are not just offered a palliative care consult. It's just part of your evaluation. At Dean, they're just starting this as of this summer, so they're working that out. But I think, one of the ways to really accomplish what you're talking about is it has to be part of the workflow. And I know in Wisconsin we have many areas that don't have outpatient palliative care, and right now that's a problem for us. Thank you.
Well, thank you for mentioning outpatient palliative care. Let me give you the big picture for palliative care. And actually, before that, let me just say something about Gunderson Lutheran. For those of you who don't know, Gunderson Lutheran is probably the most innovative health system in the country regarding advanced care planning. That's the Honoring Choices. It is such a well-integrated part of the process, and and including families about understanding the interests of individuals around their care and their advanced care planning. It's just absolutely magnificent. But palliative care now exists largely in the hospitals. And the larger view of what palliative care should be and where we are moving toward, and this is being led by the Center to Advance Palliative Care. If you want any information, Center to Advance Palliative Care, a woman named Diane Meyer. The notion is to move to primary palliative care, meaning that the physician who typically interacts with a person who has complex disease, pain, symptoms, that person will be competent in palliation. So primary care, an internist, an oncologist, that they'll be competent in palliative care. And mind you, they have not gotten a tremendous skill set. So this is training that needs to occur. Primary palliative care. Secondary palliative care would be to have palliative care available in the community, meaning the experts available for consultation with people who have needs that are beyond what that competent primary palliative care can provide. So an expert in the community. And that is a new area that is growing, how to support community-based palliative care experts. And then tertiary palliative care is palliative care as we know it now, which is in the hospital. And that exists. Most places have a palliative care team or unit in a hospital. They can provide palliative care consults in the hospital. But the notion is, you want to prevent somebody from going into the hospital. So great, palliative care is in the hospital, but you want to keep somebody out of the hospital. So how do you manage those pain and symptoms without sending them to the hospital? So there are ACOs that have been investing in palliative care in the community. There are, this is something for payers and systems to be thinking about, the investment of community-based palliative care. Remember those charts, the 75% reduction in hospitalization? This is a real opportunity also because it's more than just oncology. This really is the opportunity to look at all of those things that cause frequent flyers to go in and out of the hospital. So thank you for that. Well, I thank you very much.